Okay, good afternoon, everybody. Thank you for registering for this BSIR webinar this afternoon. My name is Dr. Previn Walker. I'm a consultant interventional radiologist at the Royal Liverpool University Hospital. And my co-moderator is Dr. John Bell, who I'm sure many of you already know, who works at the Christie. We've got a very interesting schedule this afternoon, which I'm sure you'll be very interested in. We're going to start off with a good friend of mine, Professor Fred Lee, who's many of you probably already know. Fred is a professor of radiology and biomedical engineering at the University of Wisconsin in the United States. And Fred has had a long-standing 25-year plus experience and interest in minimally invasive tumor ablations, leading him to establish about 25 years ago the Tumor Ablation Laboratory at the University of Wisconsin, which I can personally say is a phenomenal unit and one of the first of its type in the world. He's published over 200 scientific publications and is also a keen innovator and a founder of 3 venture-backed biotech startup companies devoted to cancer treatment. And in particular, many of you may already know that Fred was one of the founding members of New Wave Medical, and he remains as consultant for them. He's going to give an interesting talk to start off with, talking about how the CT-guided interventions have evolved over the years. And he's also going to give a talk about how to tackle complex CT-guided interventions. We're then going to have a talk from Eric de Cavilla, who is going to give us a talk about complex CT-guided interventions. And we're also going to have a talk after that by Professor Alban Denis, who is going to talk about complex CT-guided liver ablations. We will have a Q&A session at the end, and I would encourage you to contribute to that because it will contribute to your CPD points. We will also, after the Q&A session, have a workshop, and I would really encourage you to stay for that because we're going to have some very interesting presentations from Emactis, who are helping sponsoring this webinar, as well as Fred is also going to give some further tips and tricks about lung biopsies. So before we kick off with Fred's talk, I just wanted to thank the BSIR for this first global international webinar on CT-guided interventions. The BSIR, as many of you know, is a phenomenal organization, very dedicated to education in interventional radiology, and it's phenomenal that they've been able to put together these webinars in these very difficult times. I'm very grateful for the effort they put in, particularly to Ruth Moss and Scott Clark, who has been helping with the IT side of things. So without further ado, I think I'll hand over to Fred for his first presentation.
Good afternoon. Today I will be speaking about CT-guided interventions, a little history, and how CT navigation may fit into your daily practice. These are my disclosures. CT-guided intervention is not new, having first been described in 1975 by John Haga at Cleveland Clinic. Here are some images from some of the first CT-guided interventions performed in the world. Now, there are currently 2 ways of doing CT-guided intervention. One of the ways, the original Haga method, is walking in and out of the room during and after needle repositionings. The other method is a little quicker. It's CT fluoroscopy. This has been available since the mid-1990s, and this entails tapping on the foot pedal when you're interested in looking at an image. This can be done using an intermittent tap method or continuous CT fluoroscopy. Now, looking at conventional CT interventions for a moment. The largest paper on this topic is from Mass General and was recently published, and they looked at 8,000 patients that had all manner of CT-guided interventions. The take-home message from this paper is that it took a mean of 9 scans per patient to go from the skin surface down to the target with your needle. This entailed an entire range of 842 millimeters of scanning, or about 9 centimeters per scan. So just remember, a total of 9 scans per patient, each of the scans about 9 centimeters. Importantly, the physician dose, the radiation dose, was 0 for these cases because the physician is not in the room during scanning. Now, the disadvantages of CT intervention are well known to all of us and primarily relate to the inefficiencies of the technique, which requires the physician to walk out of the room after each needle reposition. Because of this, there's a tendency to push in the needle fairly far with each reposition to try to speed up the procedure, which can lead to tragedies like this one where a needle was put through the aorta. The alternative to this is CT fluoroscopy, which I'll describe in just a moment. But for conventional CT intervention, the trump card and the reason why this is still so popular today after 40 years is that the physicians receive no radiation from the procedure. Now, CT fluoroscopy is closely related, and this is where a limited Z-axis scan is performed when you trigger the device, generally with a foot pedal. There are a couple of ways of doing this, continuous or tap method, and we found this to be highly efficient, about 2 to 10 times faster for a procedure than conventional CT intervention. There are smaller incremental needle positions which appear to be safer. Unfortunately, the physician is typically in the room, leading to radiation concerns. I believe that's the number one problem today is physician radiation with CT fluoroscopy. And because of concerns over radiation, the image quality is generally very poor in an attempt to decrease radiation to the physician. There's some other limitations to CT fluoroscopy related to the limited Z-axis scanning. Here's a typical case in a large American patient where even though you have bulky lymphadenopathy in the retroperitoneum, it's hard to see on the CT fluoroscopy images because of the large amount of image noise because of these low radiation dose scans. In our university, we found that with our trainees and faculty, there's about 30 taps or quick checks per case. Now, the radiation dose for each of these taps is very low, but the numbers add up very rapidly because each tap is a multiplier. And so this can be a fairly substantial radiation dose. Now, CT navigation is entirely different. This is a CT data set that is combined with an electromagnetic or optical fiducial and sensor that overlays the needle position on a setup scan. And this is a hybrid system, and they were designed to combine the best features of conventional CT intervention and CT fluoroscopy. Importantly, this is not a CT fusion system that you see with a lot of the ultrasound companies, with ultrasound CT fusion, MRI fusion, PET fusion, etc. This strictly uses a CT data set and reconfigures it in a way that's very useful. Now, importantly, this is what I find most important about these types of systems, is that the CT setup scan is obtained immediately before the needles are placed, and therefore the patient is in the treatment position, and any movements, as long as the patient doesn't move, these systems can be extremely accurate, down to millimeter precision. So this is a Venn diagram that shows the overlap of the conventional Haga method that's been used for over 40 years and CT fluoroscopy, and how CT navigation takes many of the features from these two systems and combines them to be a more ideal system. This is fast, you have millimeter accuracy as long as it's performed right, and most importantly, the physician receives no radiation and the procedure can be very quick. Now, there are some limitations and cautions to these, and much of this depends on which system you're using, but this is not a real-time system. It's close. You don't actually see your needle. The patient needs to be still or stationary throughout the procedure, or you can have navigation errors. And there are multiple systems out there, and the system design does matter. So I would urge you to look very carefully at each particular system. This is not magic, and a fair amount of physician skill is still necessary to do a good job using CT navigation, just like any other medical procedure. With that, I'll turn the podium back to the moderators, and I'll speak to you later about CT biopsies. Thank you very much.
upload in a minute. Can I just take this opportunity to remind all the delegates that I'd really encourage you to put your questions in the Q&A section, which Dr. Bell will be moderating for. And I'd really encourage you to put your questions forward for that, because it will contribute to your CPD points. And just a quick plug as well for the workshop afterwards. Please do stay for that, because I think it will be really valuable given the excellent talks that we're listening to this afternoon.
Good afternoon. My second topic today will be complex biopsies with CT navigation. Now that you're familiar with the navigation, my second topic today will be complex biopsies with CT navigation, which have to do with any electromagnetic tracking or navigation. Now, the indications for CT navigation in our practice are fairly straightforward. We use it for CT biopsies in the abdomen and pelvis. We use it for lung biopsies, especially in the upper lobe and larger masses, ablations, drainages, and for all of the lung and upper abdominal procedures, we do our scans in end expiration. In that way, we don't have to account for motion in any way. Now, I'm going to give you a few technical tips, and then at the end, I'll show you a video of a complete procedure, which I think will pull all this together. Now, the first technical tip is that fiducial placement is key. The fiducial needs to be mounted in a stable location, and it needs to be secured well to the body, and you can't bump it. The fiducial and the sensor, which gives you the needle tip location, are very closely linked. And so if the fiducial moves, the tip of the needle will move as well. And so you need to be very careful about this particular topic. Here's a case that I did early in my experience. And as you can see, my target was a node in the retroperitoneum. And when I placed the needle, I found that the needle tip was medial to the target. And I didn't really understand why until I looked more carefully at the fiducial. And you notice that the fiducial rocked on the patient. It moved. And therefore, it dragged the needle more medial than my target. This was fairly easily corrected because the scan that I took, that check scan, now updates the system and allows me to replace the needle more laterally. And as you can see on the final scan, the needle position is now perfect. Now, people ask me, how many check scans do you get and when do you get them? And this is fairly straightforward in our practice. If you notice, I only did 3 scans for needle placement on the last case, whereas a typical CT-guided intervention case from that study I showed you is 9. So we save 6 scans. I tend to do a setup scan and 2 check scans in the majority of cases when I do the procedure. I first numb and get the first check scan when I place the guide needle down to the first critical structure, and I'll show you that in the video. The system is extremely accurate for depth, and you won't overshoot. That's one thing I think that is really important to understand, is that you won't overshoot. You won't go too deep. And there's a simple geometric explanation, is that if your planned trajectory is fairly straight towards the critical structure, in this case, the pleural surface, any deviation will make you short of the critical structure. It won't put you long. And so you can pass your first needles with impunity down to and just a little bit short of that critical structure. So you don't have to worry about overshooting. Here's an example. You can see my setup scan on the left. The first check scan is done after I've numbed along the path to the pleura, and then I've placed the guide needle down to the pleura. So I didn't look in between the first setup scan and the first check scan. And then between the first check scan and the second check scan, I simply place the guide needle down into the mass before I do my biopsy. And so this is a fairly typical number of scans that I do. Here's one of my partners, a scan that he did. This is an ablation case, and you'll notice this retroperitoneal liposarcoma. There are no critical structures along his planned entry path. So he did this all with 1 check scan. He did a setup scan, 1 check scan, used that scan to place the needle, and he was in perfect location. So that was done by Tim Zemlevich. Here's another case. This patient has a GYN malignancy and a new iliac lymph node that they wanted biopsied. And as you can see, this is an extremely large patient, and this was a long ways in to get to this target. And I couldn't put the fiducial on a bony structure, which I prefer to do, just because there was a large amount of fat overlying all the bony structures. So I put it fairly close to my target and was careful not to displace it at all. And here you can see I've done one check scan. I numb and then place my needle down to the first critical structure, which in this case is the iliac vein. And then my second check scan is when the needle is in position ready for the biopsy. So these are very quick procedures that you can do with a minimal number of scans. A few other important technical tips. Don't bend the needle. That will make the system inaccurate. A stiffer needle is more accurate because it tends to stay in the plane a little bit better. Be careful about the fiducial. The first case I showed you where I misplaced the needle medial was because I had leaned on the fiducial and it displaced and moved. So just be careful of the fiducial. Advance along the natural path of the needle. It's best if you can do it in one motion. If you need to do a correction, I pull back pretty far so that you don't bend the needle and it becomes very accurate. I put the sensor at the back of the needle. Some people put it at the front, at the skin surface. If you place the sensor at the back of the needle, the tip position becomes very accurate, and I like that feature of it. If you get lost, just do another check scan, and that updates the system and gives you a very updated data set to work from. I'm now going to show you a video that I believe pulls all this together, and I'll explain what I'm doing as we go along. This is an iliac lymph node biopsy. So this patient had a history of cervical cancer and a positive PET scan, and you can see the internal iliac target. We place the fiducial on a stable surface, secure it really well, and then do your setup scan, just 1.25 millimeter slices, no overlap. We then push the data to the CT navigation system and find our entry point. You can see my nurse is doing that here. She's quite facile with the system. And then we do all the usual stuff, prep and drape. You'll notice I'm not wearing any lead, which is a nice advantage. Numb skin and subcutaneous tissues, drape the probe and sensor. And then I usually use a spinal needle on a syringe to numb down to the first critical structure, just short of the first critical structure. And that's what I'm doing here. I like to numb through a spinal needle rather than the guide needle because I think it allows you to place the guide needle a little bit more accurately. So here I place it down. I'm short of the iliac vein, which is the first critical structure. And now I'm going to place the guide needle. Try to go down the natural path of the needle. And as you can see, I'm going a little bit lateral. The natural path of the needle is a little bit lateral here, which is fine. And I'm going to advance a little bit. And then I'll do a check scan once I'm just short of the iliac vein. So here's the first check scan, and it shows that the needle is lateral to the desired location, which I had expected based on the CT navigation. So now that check scan gives me updated data, and I use that to place the needle right into the target here, right short of the target. And as you can see then, this is my second check scan, and you can see I'm exactly where I want to be, just short of the iliac node for the biopsy. The pathology was consistent with a cervical primary. So based on this and our experience with CT navigation, there are a few important technical tips. I've told you to be careful about the fiducial. Can't overstress that. Don't bend or torque the needle. Go down the natural path of the needle trajectory. The depth is very accurate. Don't worry about overshooting your structure. You'll come up short, if anything. So you can go right down to the first critical structure, both numbing and placing your guide needle. Once you've done your first check scan, I generally can place the needle all the way to the target in most cases. Occasionally have to do an additional check scan. And when in doubt, an extra check scan is not a disaster. After all, that means you're doing 3 or 4 scans rather than 9. With that, I thank you for your attention, and I'll turn you back over to our esteemed moderators. Thank you.
Okay, thank you, Fred, for 2 excellent presentations. So, a great history of CT intervention, followed by the role of CT navigation, and that really sets the tone very nicely to move on and to look at some more complicated cases. We're going to do a poll now, if that's okay, just for a little bit of audience participation. So that's about 200 people who've joined us for this webinar. So we'd be really grateful if people could just complete this now, just to get a gauge really as to how you feel CT navigation would fit with your practice. So how often would you use CT navigation in your interventional practice? That includes drainages, biopsies, and ablation. And we'll look at the answer to this after the next presentation, but maybe with the cases that you see after this, it might, your viewpoint might change, it might stay the same, but it'd be interesting to get a general feel. I'll just remind you that there is the Q&A section to this, so there should be at least 200 questions for our esteemed panel to deal with at the end, so please answer as many questions. It's not often you get this level of expertise together, so please take advantage of that. So it gives me great pleasure now to introduce Professor Eric de Covillier from Paris. Eric is an early adopter of new technology, so he works with 4D CT. He's really been at the forefront of cryoablation, so he's seen Eric talk a number of times and give excellent presentations, and everything he seems to do seems to be very challenging, takes on a lot more adventurous cases than I do, and he's also an early adopter of electromagnetic navigation. So all these videos are pre-recorded just to hopefully avoid any IT issues. So all the panel, as you can see, are all moving and they're all very alive and sitting in front of you, but the videos are pre-recorded. Thank you, Alban, for the proof. Okay, thank you. This is Eric's presentation.
So welcome to this webinar. Let's move quickly to the first three cases. The case number one is a 67-year-old patient with prostate cancer, Gleason 7, and at diagnosis he had an osteosclerotic bone lesion in the ribs and in the spine. As you can see here, you have bone lesions here in the spine, but the patient refused intervention in the C-spine. And so the only thing that the patient accepted is a biopsy of one of these two ribs. You can see the lesion here. So looking at CT, the lesion is here on the anterior aspect of the sixth rib, and it's not easily accessible. But if you transfer the images to the PACS, you can detect that there is a free access to this lesion entering from the cartilaginous part of the rib and then going in the shaft of the rib. So let's move now to the Invectis workstation. So this is case number one, and in that case we have a small osteosclerotic lesion on one of the anterior aspect of one rib. And if I navigate through the slices, I see my lesion here, and it's very difficult to approach this lesion transversally, so we have to go within the ribs and to maintain our needles between the two corticals, like as if we were doing the procedure between rails. So for this, I will do the procedure using an anterior approach, and I will direct my device towards the right of the patient, and I'm checking. I see the lesion here, slightly more external here, and the idea is to enter within the cartilaginous portion of the rib, and this will give us a guide to enter the rib. So it seems easy, but in fact it is not so easy. So we have to select. So here we have the lesion in the two planes, the transverse plane and the oblique sagittal planes. And once you enter the rib, it's very difficult to go out because of the two corticals. I've determined my entry site, I've determined my optimal trajectory. I can store the trajectory to be able to find it again in case I move my needle. It's more easy to find again the trajectory. If I change my mind, I can delete it, and I can store another one. Let's say that one, for instance. Good. Okay. And with that, it's time to insert our trocar and to do the biopsy. Also, let's move to the series with the needle. So now we can remove. So now we've determined the entry site. We enter our needle, and you see here that this is the external cannula, which is just in front of the osteosclerotic islet. So we're ready to insert our biopsy needle within the external cannula. So you see it's very, very safe, and we have approximately 10 to 20 millimeter to deploy our inner stylet. That's fine, and we made it. In my experience, I have no other option to biopsy such a lesion. Just to remember, this patient was planned for a surgical excision of this osteosclerotic lesion, but of course the patient refused, and we decided in the tumor board to attempt a biopsy with the Imactis system using a double oblique approach, and it worked. Well, let's move to the slide now and check the final position of the trocar. So here is the solution with the trocar in place, and you see that the trocar deployed passes through the osteosclerotic islet. Now, patient number 2 it's a 60-year-old patient with a history of breast cancer 10 years ago, and this patient had an increase in tumor markers, and at the FDG PET there is an FDG-avid anterior mediastinal lesion, but unfortunately the location is not easy to access. As you can see here, the anterior approach is, I would say, not easy, because you either have to go through the sternum or to go through the lung. Hopefully, if you do some reconstruction, again with your PAX workstation, you see that there's a free access to the tumor passing over the sternum. This is what we will attempt to do with Imactis. So now let's move to the console. Okay, so let's start with case number 2 now. You see, if you navigate through images, that there is no free access to the anterior mediastinal lesion. So this is the reason why we used Imactis. And looking at the images, at the surgical image, it clearly shows you that there is a free access to the lesion using a suprasternal approach. And I'm moving my device up, and then I'm angling slightly to the left, and then down again. And I managed to align the entry site and the lesion. The only thing we have to pay attention at is we have to be careful of the depth, because at the lower aspect, at the deepest aspect of the lesion, we have the emergence of the left carotid artery, which can be an issue if you push your needle a bit too far. So now we are ready to insert the needle. So this is what I'm doing here. And I'll go in. And now, because I have restored in my console the standard length of our most frequently used needle, I can determine the position of the tip of the needle. And in that case, I move the device up. So you see that there's plenty of room to go in. So I'm going down again. I'm inserting a bit my needle, and then testing again. And now I think it's not bad. Maybe I can withdraw a bit the needle. Okay, and now here I'm ready to deploy my stylet, assuming I have needle through of 2.5 centimeter. It's fine, and I can puncture and do my biopsy without entering the arterial structure. Okay, let's check on the control image. Okay, so now the needle is in place in the lesion. You know that the tip of the needle is not against the carotid artery, and that the direction is okay. If we want to modify our trajectory, we can sample another part of the tumor, more medial one, as is as shown here. Let's move to the last series. Okay, and this is a second needle through. This one was more laterally located. You see that in my case, you can sample whatever part of the tumor you want, more lateral, more medial, or again, even more medial here, or toward the feet and to the head. So in that case, we demonstrated the recurrence of breast cancer. Well, thank you for that case. And this is the final control we have after during biopsy. You see the stylet is deployed here in the lesion, and we are far from the aortic arch and the supraortic arteries. And now let's move to the final case. It's an ablation case. It's a patient, 79-year-old. It's a metastatic colorectal cancer with remitting lung nodules. And this is the CT. You see the diagnostic CT obtained in supine position. The nodule is here, and you have free access to the nodule. But as usual, unfortunately, when the patient is prone, there is a rib that blocks the access to the nodule. On the other side, you have the scar of a previous lung ablation. So in that case, because we don't have free access in the transverse plane, we will have to use double oblique planes. And because we want to place 3 needles, this is the expected needle trajectory that we will plan. This is case number 3 now. As shown in the presentation, there is one nodule here in the right lower lobe, and as I showed you, there is a rib that intervenes in the needle pathway. So in general, we try to place a needle side by side on the same slice. It's easier, but in that case, it's not possible. So we will have to use a double approach. You know, during ablation in the lung, you use several cryoneedles in general for sub-centimeter nodules. And in that case, we decided to place 2 cryoneedles. So we had to use 2 different trajectories. One from the top, with that direction approximately. So the trick in that case is to visualize the nodule on the sagittal planes to be able to place the needle, whereas on the other image on the left, the nodule is not visible. So you place the needle with only one guidance tool. Then once this cryoneedle is placed, we have to place the other one. So we will move to below the rib, and again, if I go here, I go in the nodule. I don't want to go in, so I slightly move my guidance tool, and here I'm able to place the second needle below the nodule. So one needle above the nodule and one needle below the nodule, just as if you were using chopsticks. Now let's load the final control with the 2 needles in place to look at what we did. So, as expected, without any surprise, we place the two needles here. So one needle was placed here, just at the upper aspect of the nodule. Here, it just touches the nodule without entering in. And the second needle is placed here, more laterally here, into the site, and it's located here. And with that, we are ready to start the ablation, and control is not bad. And this kind of needle placement is not very easy without the use of guidance tools such as Imactis. Well, thank you. And now let's move to the solution, and this is a solution with the two cryo needles taking into the tip, between the tip of the cryoprobes, the nodule, just as if we were taking a pea with chopstick. And more than everything, I love freedom, and this kind of tool, namely Imactis, gives me a degree of freedom that I've never reached before. Thank you for your attention.
Okay, thank you very much for those excellent cases, Eric. I think we lost the final bit of the video there. I'm not sure if that was me or everybody, but Eric, I don't know if you could just describe the final result there from the cryoablation case, just to fill in for the loss of the video at the end.
Yes, I don't know if everybody was lost. I lost the video at the end. For me, it was okay. But just in the end, we had a successful placement of the two needles, one above the nodule, one below the nodule. It was taken into the pinch, and we were able to ablate the nodule.
Perfect. So it was just me, just to clarify. My video was running a bit late, but I've seen it before, and it was so some excellent cases. I'm sure everybody will agree that CT navigation there really allowed Eric to take on what I would consider to be some very challenging cases, and obviously got excellent results and very safe for the patient. We're getting a few questions coming through the Q&A now, so thank you for that. We're going to go to another poll now, so we're going to ask a second question just to see where people feel that they would use CT navigation most. So we saw those three complex sites where Eric targeted. So in your practice, where would you see the role for CT navigation? You see in the pelvis, liver, lung, or bone, where would you feel that you'd use it most often? So for our final presentation now, before we move on to the Q&A session, is from Alban Denis. So Alban is well known to everybody. He's had a really easy start to the year. He became chairman of in Lausanne recently, so congratulations on that, Alban, and also the scientific chair for ECIO. So incredibly easy year for you. No chaos thrown into the mix at all. So we're now going to see a presentation from Alban focusing on the use of CT navigation in the liver. So thank you.
Good afternoon and welcome to this BSIR symposium sponsored by Imactis, and I will share with you our experience and our thoughts about complex liver tumor ablation. So challenging liver tumor ablation is a more and more common situation because we treat smaller lesions than what we did in the past. So the problems of the visibility and access to lesions is more and more frequent. We also tend to use multi-needle ablation, particularly in complex positions such as subcapsular or deeply located tumor. The shape of the lesion might be variable, the shape of the ablation zone as well, particularly when you use multi-needle application. And the quality control that you want to apply at the end of the procedure is also complex. If the lesion was not visible, within the modality that you use for ablation. For instance, if you ablate a lesion that you control at the end of the procedure by CT, but that you have punctured using ultrasound, there's no way that you can match pre-treatment and post-treatment images. On top of that, there's the problem which is also occurring with microwave, is that when you ablate with microwave, the tissue is shrinking. As you see on that example, coming from new wave, that shrinkage is not the same in every single direction. Perpendicular to the needle, shrinkage is proeminent, but in the other axis, along the needle axis, there's no shrinkage, but a deformation of the liver. It's also true live when you look at the liver, that you place 3 needles, and you will see the liver capsula will retract very early at the beginning of the ablation. All that is critical because if we want to compete over time versus surgery, we need a quality control at the end. And we know from 2 publications, one in hepatocellular carcinoma, the other one on colorectal mets, that having margins really make the difference over time. Here, they have compared margins superior to 5 millimeters to margins inferior to 5 millimeter in terms of rate of tumor progression over time. And when the margins are small, you see that you reach up to 50% of local recurrence over time. Exactly the same with colorectal mets. Even if there's no microsatellite nodule in that disease, we know that the tumor is more or less infiltrative at the margins. So the bigger the margin that we can achieve, the better the results in terms of local recurrence. Even more complex for subcapsular tumor. We know that we should not puncture those tumors directly, even if we can ablate them very easily by doing a direct puncture, because there's a risk of tumor seeding. So how do you manage this kind of situation? In terms of ablation, but not only ablation, also in terms of quality control at the end. So this is a very large hepatocellular carcinoma, nearly 4 centimeters in one direction versus 2.5 in the other axis, at the anterior aspect of segment 4 at the junction with segment 3. So what we did, we injected lipiodol to make the tumor visible, and we applied the no-touch technique posteriorly to the tumor in that direction, but also posteriorly in the other direction. So the tumor itself was taken like in between 2 brackets to be destroyed by the ablation. 10 minutes, 60 watts. And at the end, since we considered the tumor was probably already more or less treated, we made a direct puncture to make sure that the superficial aspect of the tumor was treated. And this is a control at 6 months with a segmentectomy of the tumor, complete destruction of the tumor. You see the margins are vascular, so it's really vascular limitation because we have occluded the portal vein of segment 3 during that ablation. Since we need those possibilities to make sure that we position properly the needles and then ablate in the proper position and confirm that we have good margins, some solutions popped up from the companies. This is the ablation confirmation software by New Wave, which is probably an interesting tool. You define the target on pre-treatment CT done during the procedure, so in the same position than post-treatment, where after ablation you will look at the margins with contrast injection. You place your needle, and since you have segmented the tumor here, and the soft is able to recognize the needle, you can make sure that your needles are close or within the tumor. And at the end, you confirm your ablation. So in real life, what does it give? This is a tumor here in segment 7, clearly visible on MRI, but also visible on CT. So you segment manually the tumor on the first CT, you place your needle and you realize here that, for instance, this one is not in a very good position. So you have one needle inside, two other at the periphery. Why not? But probably not perfect. So this is quite interesting and probably a good software, at least for this part. So you reposition your needle. It's one more time not perfect, but at the end you decide to treat. And then you have the lesion here, the margins that you should have, and then the ablation area, which is hypodense after contrast injection on the CT at the end of the procedure. But pay attention to that. That software allows you to shrink or to expand that ablation zone that you have done, taking in consideration that here has shrinked because it's microwave. So if you shrink like by 50%, of course the margins will be big because the margins will stay at the same place, but the tumor will shrink. That's completely artificial. And that shrinkage that you decide here is in every direction, while we know from real life that it's not the case. So interesting tool. It has to be validated in real life, but by far it doesn't solve every problem in every situation. So for using this software, you must have a lesion visible before ablation using the same modality as the confirmation acquisition post-ablation. The less movement as possible between the two sets of images, so respiratory movements, arm position, etc. should be more or less the same. It does suppose no shrinkage of the tissue after ablation or a predictable shrinkage homogeneous in 3D, which is never the case, and without variations depending on tissue characteristics. If we put all that together, having an ablation confirmation solution is probably something which is not reasonably achievable. And this is also why those software so far have not confirmed their benefit on real-life series with a lot of cases. So we went in a slightly different situation where we developed with Imactis a solution through a research project that aims to solve differently the problem of the confirmation. And the first point was to be able to use sets of images before treatment, which are not the same than the CT. It basically allows you to have the lesion visible under MR, but not under CT before treatment. Like in this case, you see that small lesion that was segmented. You have that CT acquisition where the tumor is not visible. You reformat and fuse the two sets of images. MRI is in purple and CT is in green. You make sure in the 3 direction that the two sets of images are fused properly using rigid and elastic reformation. You validate the reformation using that color view. And then you have your lesion visible. And if you fuse with post-treatment CT acquisition, you also have the margins around it. And all that could be done with a solution that allows you, on top of that, to retreat easily the areas where you think your margins are not sufficient, like that lateral part, for instance, here of the tumor. So we try to validate the process globally using cases in which we had recurrence. They come from 2 randomized studies with a prospective follow-up. So recurrence are true recurrence. So we use the post-ablation CT, automatic segmentation of the ablated area, fused with pre-treatment MRI, and we took the tumor here in blue in the center, the ablated area here, and defined in red the zones where the tumor is either in contact with the margins or even outside of the margins. And that's probably good enough to be able to bring a needle here using the MACTIS guidance system to reablate that area at risk. So where did we go in terms of validation? So we used some quite complex mathematical evaluation of the situation immediately post. So this is a tumor pre-treatment in red. This is the ablation area on the post-op CT. And we looked at what's happening. Is it really predicting what's happening in the future? Local recurrence, because in that case, all the patients had local recurrence, the shape and size might increase. And we know that the post-ablation zone, on the contrary, is shrinking at 3 months. So what we compared is those points, both in terms of direction, but also in terms of length. And we looked if it was, in a way, logical in terms of evolution. So first case, a patient with, you see here, the truth distance with the estimated distance in millimeters, a good R value with a p-value, it could not be better. And this is the case. The tumor is actually only partially treated here in the actual coronal and sagittal plane, and the recurrence, this is the follow-up, so the ablation area has shrunk, and you see that the recurrence is properly located. It's really in the part of the liver where we should have retreated. If after the treatment we would have added needles here, probably the tumor would have been properly treated. Things are never that simple. This is another patient with here a negative correlation of the distance. And here is the reason. The tumor was here abutting the IVC and the ablation area here, there. So we pretty much covered the tumor, unless probably the lower part of the tumor. But the recurrence is actually on the other side. You have the IVC here, the ablation here that shrunk, and recurrence on the other side. Like if we would have left, probably because it was not visible, a microsatellite here that was not treated, or it's a new tumor that is actually growing, but not where we could have expected a recurrence, exactly on the other side. So that's a new lesion. No way that you will predict this kind of recurrence with those softwares. So in terms of correlation, the results are quite satisfying because in nearly 70% of the patient, we have a very good positive Pearson R value over 0.64, which is quite good. And I think that here, if we want to go in the future in ablation confirmation software, we must have it, but we also have to be modest and admit that it's a complex issue. And it's often taken by vendors that we will be able to predict recurrence or non-recurrence. So at the end, it should give you the security to say to your patient, we have good margins, you won't have recurrence. But that takes in consideration a lot of factors, the tissue shrinkage by the ablation device, 2D, 3D view, the quality of the reformation, all that is very complex. And also the tissue heterogeneity between the tumor, the normal liver, the diseased liver, etc. So probably each patient has those shrinkage coefficients, which are more personal than predictable. But you could also consider that more modestly as a guide for areas at risk of recurrence, that's all. Even if your predictive value, positive and negative, is not that good, in a way, you're able to say, in that area, I'm not completely satisfied, But then you will need sophisticated solution for reformation and fusion, because those areas at risk, there's no way that you can retreat them unless you have a fusion and a guidance system like Imactis to place your needle in those areas, because at the end, only CT could be used after injection of contrast, but as we all know, ultrasound is no more a valid guidance system after ablation. Thank you.
So thank you to all the speakers. So we're going to go to a question and answer session now. Just to get started on that, we did a poll at the start asking people what their feeling was, where they feel that CT navigation would fit in their practice. Majority of people, 37%, said that they would use it often in their practice. 27% said sometimes. 29% said never. Maybe that's changed after seeing Eric's cases in particular. They might have a different answer to that question now. But if you look at your practice to the panel, where do you, when you vet forms, vet requests for CT intervention, where are you using it often or sometimes? Do you see that it's changed your practice? Or if I start with Fred with that one, is that okay?
Okay, hopefully you can hear me. I just unmuted my mic. I would say that I use CT navigation very often. I would say approximately 50 to 75% of lung cases are usable with CT navigation, and in the abdomen and pelvis, virtually every place that you go is you can use CT navigation for it. I like it because I think it speeds up my practice. There's less radiation, importantly to me, and I think it gives you quite a bit of confidence in the needle trajectory, that when you place a needle, you know where the critical structures are. You have excellent imaging, not that very limited imaging with CT fluoroscopy. And so I'd say I use it 50 to 75% of kind of my general practice sort of cases.
And Alban, from your presentation, the suggestion is, this is going to improve oncological outcomes as well from your research. So would you be using it in all liver ablation cases?
Well, what we do in daily practice, we use it as a problem solver. So when we biopsies deep located lymph nodes, like the case of Fred, or retrograde approach for adrenals, mediastinal lesions, it's really helpful and speed up, and also gives confidence for the procedure. So this is the way we use it today for complex biopsies. We start to use it to add margins where we think we don't have sufficient margins. And here, there's no other way that you use this kind of system, because placing the needle in the proper position versus insufficient margins takes a fusion system and a guiding system to go through the proper axis to reach the area where you think you are at risk of recurrence. It has to be proven, that benefit for sure. It will take a large series and probably big registries. I know that Fred is working on that with a new wave. We will see the results. I think it's a new way to do ablation. Make sure at the end that you really treat everything, not waiting for recurrence, and really completing ablation the best we can. And then it's mandatory that you have it. There's no other options than using this kind of system.
Thank you, Alban. And Eric, a lot of the questions that have come through are related to the lung. So people feel they would use it most frequently in the lung. About 50% have said that. Our esteemed president, Ian McCafferty, has asked about respiratory motion. I didn't mean to laugh when I said esteemed president. But he talked about respiratory motion and what you do to address that. Can you give any advice about how you do lung biology?
Yes, I was listening with interest to Fred's presentation, and he told us in one of his slides that he preferred the full expiration. In my experience, I prefer shallow breathing. I think it's more reproducible, And you're allowed to do one or two control to monitor the position of your needle, and you can adjust. It's like you use a staircase, and sometimes you can take the ramp. You can take the ramp. You can release the ramp. The rail, and so you can trust blindly the Imactis system, but sometimes you must open your eyes and you must correct by yourself the trajectory. So it's a tool, but it's not always a problem solver. So in the lung, we have sometimes to reacquire a new set of images or to monitor the position of the needle. It's like golf, it's not always a par 3 or par 4. Sometimes you need to, you don't always do a birdie or all-in-one. Sometimes you have to check in between.
I might just follow up very briefly Alban's comment, because I couldn't agree more about using the system during ablation. One thing that I would say to new users especially is that what we found out is that if you only use the system for very complex, difficult cases, it's hard to get good at it. And one of the things that now I do is that for every ablation case that I do, I drape it and have it ready. And even if I don't necessarily need to use it in a simple case to place a needle, we still practice lining up the approach, and then we look at margins just like Alban, and then you only know if you need it after your initial CTs come out post-ablation and you're concerned about a margin. And so then we'll do exactly as Alban does, is that we'll put a needle right down where we're worried about a margin, combined with the post-contrast CT data set. But I would caution people that if you use it, try to use it fairly frequently so you become an expert at it. If you don't use it except for extremely difficult cases or problem solving after you've gotten yourself into trouble, then it will be less than ideal. That's just my opinion. Curious about Eric and Alban, how they feel too.
Thank you, Fred.
Fred, can I just follow up on that comment about your use of the device? Given the fact that you've probably used this a lot more now, what percentage of cases do you think that you use the guidance system versus just pure ultrasound, would you say now?
For ablations?
Yes.
So the way I do most cases is that we will drape a Imactis and bring it up onto our field, and when we have our preferred trajectory with an ultrasound, so we bring both ultrasound and Imactis to both cases, to every case, and we'll look with ultrasound at the lesion, and then I'll use Imactis as a survey to see where the bowel is. Am I happy with the trajectory of the needle placement? Where am I going to put a second needle? That sort of thing. And so I use it as kind of an overall landscape view as well as with ultrasound. But I still do place most of my needles with ultrasound, but use Imactis to confirm the trajectory and to look at other vulnerable structures around. You often don't see the bowel as well as you think you might. And so I'll use Imactis to make sure that the colon's far away or the adrenal gland is in a certain position, that sort of thing. But I still generally puncture with ultrasound.
Can I add something? I think it's, even if the lesion is visible on the ultrasound, if you use a multi-needle system, it's not always easy to place a second and the third one.
Yes.
And then you place the first one, the easy one on the ultrasound, and the next ones, if you want to have a very precise space, distance between needles, then a CT navigation system like Imactis is very helpful. And since we had no more anesthesia team during the pandemic, we've done a lot of cryotherapy for liver tumors. And then you need, if you treat a 3 cm liver tumor with cryo, you place like 5 needles. Doing that on the ultrasound only, it's just a nightmare. And Imactis, honestly, was very helpful for those cases.
I would completely agree that I can't say how many numbers of cases where you place multiple needles under ultrasound and you think it's perfect, And then you look at the CT, and the needles are never exactly parallel. But the navigation system can make it much easier. They end up just like Dr. DeCavalier's chopsticks virtually every time.
One of the questions we've been asked is about compatibility with cone beam CT. So Alban and Eric, you're both using 4D CT. Can you use it with cone beam CT?
I don't use it with cone beam CT. I do most of my procedure under CT guidance. Even though I have this facility on my equipment, I don't use cone beam CT. I prefer very much the quality of the CT images.
Well, exactly the same for me. I mean, cone beam CT, we bought it in the 4D CT, but I think we never used it at the end because we always use CT. But if you don't have a CT and you want to perform your procedures in our cone beam CT, I know that Imactis is working on that solution. So it should be available as well. And it might be helpful for bone lesions, bone biopsies and treatments as well. So the solution does not exist yet, as far as I know, but it will come in the near future.
Alban, somebody has commented on, so you did a case where there was that small lesion in segment 7 or 8, which they're asking about fusion software and how you targeted that lesion, whether sometimes you use Lepidol or, for HCC, for instance, to mark lesions. But in that one specifically, how did you target it? Because it was difficult to see on the CT, I think.
Yeah, so if it's visible under CT, as you know, we work under jet ventilation, so the organ is not moving. So you can take very retrograde, complex approach using this kind of guidance tool. If it's not visible, to try to tag it with Lepidol or even negatively with like Porto-CT for the oldest of us who know what that technique is. And then you see the lesion negatively versus the normal liver. We even sometimes use Lepidol in METs, and you will see the tumor as a negative within the Lepidol tagged parenchyma. So that's solutions. I think one of the questions was how to avoid the complications on the diaphragm and so on. So you can always add fluid, but then fluid makes your navigation, if you have to use it, more complex, because the liver then will be moving within the fluid, and it makes your needle positioning much less precise. So we tend to place the needle first, lock them using tissue lock, and then place the artificial ascites to make a space between the lesion and the diaphragm. It's much easier to do it this way.
Thank you, Alban, for that answer. So this webinar doesn't finish now. It leads on to a workshop. So before I sort of close and thank the speakers, don't leave. Stay with us, because Fred is going to take us through some lung cases, which is where the bulk of the questions have sat. So please stay with us to listen to Fred's expertise. Thank you to Alban and Eric for your excellent presentations. It really is great for the British Society of Interventional Radiology to be joined by world-leading experts like yourself to raise the level of education, certainly in our country, but this is a global webinar, so it has far-reaching influence, and it's nice to see people, even though remotely at this challenging time. So thank you to BSIR and the support with Imactis, and in the UK to BVM, and particularly to Jay, our gold medalist last year, for supporting all of this. There is CPD at the end as well, so please stay put. There's lots of questions. There'll be lots of opportunity to engage with Fred in the next part of this session. So thank you, Previn. I'm not sure if you want to add anything as my co-moderator at the end, but thank you from me.
No, yes, I'd just reiterate what you've just said, and in particular, I didn't say in the beginning bit, but I think this webinar wouldn't have been possible without the support of BSIR, Imactis, and in the UK, BVM. BVM done a phenomenal job of trying to get Imactis in and some market penetration into the UK, and their support in educating about CT guided interventions has been really helpful, and that's where really this webinar is all about. So I'm really grateful to BVM, to Jay, and to Emily, who's done a lot of work to get this webinar off the ground. So thank you for that.